afternoon, and thank you so much for joining us at Rwanda Health Magazine Podcast. My name is Arafat Mugabo. Today, we are delighted and honored to have in the studio Dr. Menelas Nkeshimana, who is the head of the Department of Health Workforce Development at the Ministry of Health, Rwanda. Dr. Menelas Nkeshimana is a renowned physician who has headed even the Department of Emergency and Accidents at the University Teaching Hospital of Kigali. And thank you so much, Doctor, for accepting our invitation today. Good afternoon, Doctor.
Good afternoon, and thank you very much for the invitation.
Okay, how are you, Doctor?
I'm good.
Are you doing well?
Yes, I'm well and healthy.
I usually ask my guests, the first question is to tell me how they feel. How are you doing? I mean, in details, how is life so far? What is going on around?
Well, I would say that we are back to normal. A few days ago, maybe it was a bit hard because of the outbreak of Marburg, but life is back to its normal pace.
I mean, yourself. Yourself.
Myself also, I'm back to my usual life.
You're doing well.
I'm doing well.
To someone who is just maybe seeing you for the first time, who would love to know exactly who is Dr. Menelas Nkeshimana? Of course, many of us, we know you because we got to know you in different epidemics that broke out in the country. But to someone out there who would wish to know exactly you, the person behind the title you hold, I mean, they know you as a doctor, they know you as an educator, and they also know you as a lecturer at the University of Rwanda, maybe, if you correct me if I'm wrong. And some people have seen you as a frontline doctor. But we need to understand you behind those professionals or those careers. Who is Menelas?
Well, it's true that we get a lot of different descriptions, some of which are also related to the day-to-day job that we do, but maybe I would just see myself as one out of the 13 million Rwandans in this country, and I live in Kigali, Nyamirambo, so it's a decent, normal life, and I was born in Rwanda. I had my primary education and secondary education in this country. I had to leave briefly to undertake some studies in China for 7 years. That's where I stayed. Then I came back with a medical degree that I used. Probably that's the part that everyone knows professionally. I've worked outside. I started outside of Kigali, Kibuye. That was my first job. Then I moved back to Kigali, did my specialized training, and then I worked mainly at University Teaching Hospital of Kigali in the Department of Medicine, and I led the emergency department. Also, that's maybe another part that everyone is familiar with when I was working at the emergency department of CHUK and worked with COVID-19 response for the country. That also is some part that is known. Marburg response. So I've been close to emergencies, disease outbreak, and recently at the Ministry of Health, in charge of health workforce development.
Good. Actually, before we dive deeper into our questions of today, I have a feeling that I wanted to ask you this question. What was the drive that drove you to medicine? I mean, how did you end up in medicine?
Well, I think that will also have to do with the way we are brought up. I was born in the early 80s. There was a lot of health-related problems. Maybe that's why I became familiar with the health-related matters. I remember in my childhood, I used to have malaria almost every month.
Really?
Very serious. very severe malaria.
Because of where you used to live, or maybe because of the situation, or maybe because there was no spraying, the things you do today, or what was the case? What made it like that?
I think the timing, maybe at that time there was malaria not only in the neighborhood where I was staying, Nyamirambo, maybe it was just a public health problem or across the country, but the frequency of it was quite enough for me to remember that.
Okay, cool. So from then you said, no, I have to seek for a career that connects me with how to save people's lives.
I remember those episodes maybe as just one of them, but the years that followed, maybe in the 90s, we had also a lot of that was going on, and within families or close families or extended families, we also presented with many health challenges or across that as a young person that I was. It just captivated my mind, and it ended up being something that I was considering to pursue in education.
So, I think you've answered my question well. So, there's this question I want to ask you. Your role as a senior consultant physician at CHUK has seen you manage a range of critical cases. What have been some of the most significant lessons you've learned on the front line? I mean, let's discuss about that department, because it's one of the critical departments. We've seen, for me, I strongly believe that if you can manage to suppress that earlier and do the work diligently and manage to save people's lives, you can do it anywhere in the health department. I mean, what are some of the cases that stood out for you while you're working there? And what is it that is difficult in that area that everyone should know? Maybe someone who's listening or watching us who is working in the same department, what can they learn from you right now?
Well, it has to be something that you are passionate about. And also, I always say that there is a reason for anything. I started in the Department of Medicine. I did not start in the Department of Emergency Medicine, but I was present even in the Department of Medicine. And Department of Medicine, we have work to do also with the emergency department, because 50% of the cases that presented at CHUK at that time were medical emergencies. And the rest of the work we do inpatient management of cases. But even from the attachment that I had for the acute medical emergency management, it's something that I was very passionate about, because people go to hospitals to be helped, and if you are there and you're available at the bedside, you shape your career in a way that becomes you for all the years to follow. And as I said, in my childhood myself, I have used these services before when I had malaria episodes almost every month. These are the visits that I was making in the hospital in the night. So I get very high-grade fevers. Sometimes I would even develop some confusion, cerebral malaria. When malaria gets to the brain, you become confused, you're febrile, and you can't sleep. So I remember the trip to the emergency to see the emergency physician because of those episodes. So I could see how I could relate to that. So it requires passion. You have to be present, and also you have to be a good listener, because you might not be able to solve all the puzzles that you face in that department, but through the interaction, the person that you are caring for, they understand if you have done your best or if you're just borderline available. So that's how I would see my attachment to emergency department. Then also the emergency department was at the hospital level, CHUK. Then COVID-19, as you remember, was an emergency at the national level.
Sure.
So the same passion, the same attentiveness that you put in the emergency matters, you can also bring it to that level. I joined the national team that was in the task force for COVID-19 containment, and my role was also to continue as a clinician within that context, in complemented with other pillars that, of course, are part of the national response. So it's something that is very meaningful, something that I was passionate about. It's something that you can immediately see the impact of your intervention right in the middle of the response.
Do you have like a case that stands out for you that you remember that you intervened in, and had you not came in, this person would have died?
Yes, we always have cases to remember, but particularly there was a young man who had a motorbike accident, and the accident was very severe to the extent that his face came off.
Oh, really?
Yes, I think he crashed on the tarmac road and just scratched off his face. It was very, very serious. So these cases in the past, they would not make it to the emergency department because the deaths would happen on the crash site. But because of the development that you have made as a country, the emergency response, Sami could get to the crash site on time when he was still alive and in pain, and they were also affected. They could never believe that such extent of trauma could keep someone alive. Then they just brought the patient to the emergency department, and because of the shock that they were having, they quickly hand over to the hospital team, and the hospital team also had the same shock from the side of the extent of the trauma. But that man survived 12 hours. Again, I remember the following night, everyone who has been on shift, they needed psychological support. They had seen probably what they never thought they could have seen, anticipated to see. And I told them, like, today, on that day, the person survived 12 hours. The next might make it survive for a week, the next a month. And before we know it, that's how you come up with facial transplant and other services that never existed as a country. So there's always a start point for everything.
Really? So you mean that man was the rebirth of the facial training career, maybe in the medical department of our country, or maybe, I mean, you're trying to say that because of that man, that's why facial practice came in the country.
In other countries, that's how they start. You start with the basics, interventions, you respond on time, you do the interventions that are required to maintain someone's in life. Then you think of solutions, like what else? So if you have no face, of course, you look into transplant of things, how to make them back to near normalcy and so forth. So although it sounds like a disaster, but also from disasters, also you learn lessons that can shape the development of a country.
Okay. Welcome once again to Rwanda Health Magazine Podcast. My name is Arafat. Today, as you know, as you've seen, we are speaking to Dr. Menelas Nkeshimana here in our podcast studio. So we are continuing our conversation with Doctor. So, Doctor, I wanted us to really dive deeper into the triage. I mean, how is triage conducted at the hospital, especially in the Department of Emergency and Accidents? Would you give us the details on that?
The science...
Let me bring it easy. Let's say I bring my patient. Let's say we have 5 patients at the emergency department. And for me, I have a feeling that my patient should come first. But at times, I might find that my patient comes last. So how is that conducted? Should that be considered as negligency over my patient, or what would that be? Why is it like that?
First of all, it's not negligence. It's just the operation of emergency departments all across. They are built on something like, in the event that you have 10 patients in front of you, and they all are looking at you to go to them first, because I feel for myself, you feel for yourself. So what mechanism are you going to, what framework are you going to use to decide whom to assist, whom to treat first? That's why we come up with the category that you have seen, the most immediate need to be treated are labeled in the red category. The next, they are in the orange, then yellow, then green. So what brings up those colors, you compute the disease, what is constituted emergency. I just had trauma, I have a headache, I have seen a skin rash on my, something unusual on my skin. So you compute all that information, you compute the way they are reacting to in front of you. They can speak to me as opposed they cannot speak to me. You compute also their vital signs, the blood pressure, the pulse. You contribute also what we call danger situation or fragile type of patient, like a pregnant woman versus a young person of 30 years or 20 years. So you compute all of that, you do the scoring, you do the add up of the scores, and you put in the category. That's how you decide. I go first with Menelas, then Thomas, then Jeff, and so is going to be of least priority. And there's also time expected to be seen. When you face red, patient triage as red, you try your best to reach out to each and everyone at as much as you can, because red means their lives are in danger. If even you have, there's a mechanism in the hospital, if you have more red than you are able to manage within reasonable time frame, you activate what we call mass casualty or other unusual events, so that you receive support from other departments, because someone's life is a danger. It's a danger. Yeah.
So that simply means if you have like 10 patients who are in red, what you do, you can mobilize for more other doctors to come and help you in the department, so that you can save all these who are in red.
Yeah.
So simply red is that person who is in danger, whose life is in danger, that needs urgent rescue.
Exactly. And even 10 is too much. Huh? We don't wait to have 10 to call for help. Usually around 3.
Really?
Around 3, 4 reds arriving at the same time. You need someone else to if you are stationed at a triage and you have 3 reds arriving at the same time, already ring the bell. Because
let me hope this is not going to touch you, but I want to ask, have you lost someone that you thought you would save?
Absolutely, yeah, I did.
How did you feel about that?
You feel bad, but at the same time you ask yourself, what could you have done? So this is also part of the doctor's training. You should be able to forgive yourself if you think you have done the best of your ability, but someone dies of a preventable death. It's something that you don't get to forget. Your life, yeah.
Really?
Yeah, you don't get to forget it when you feel like this person has passed away, and if you go into ifs, if so and so, if this and that. So those ifs, they follow you.
So simply, these people need, they usually need experts who are psychologists, maybe to talk to them after. Do you do that? Because I can imagine now how many people that you've really seen dying, and you still, moving on with those faces, moving on with that on your heart, and you keep going and doing better. I mean, how do you manage that? Is that self-management, or maybe you get some outside help? How do you manage that?
Yeah, you get assisted. There are frameworks where you have to debrief and explain, speak to someone, and you go through what happens, and maybe hang on a hope that tomorrow and after tomorrow, those ifs are not going to be recurring over time. Yeah.
So, Doctor, let's talk about leadership. You've taken on many leadership roles, from heading the accident and emergency department. Now you are at the department of you're now training people, Department of Health, Workforce Development, and Ministry of Health. I mean, still you're doing also the career of lecturing and training young doctors. how do you juggle all of that? I mean, how do you manage to do that? And I mean, is it yesterday or last week? Last week I was really shocked to see. I think you tweeted that you are from. I think it's a message you wrote on your WhatsApp. You are from one of the province, and you came in another conference in Kigali, and you had gone. I think you had gone to Muhanga, those areas.
Kibuya. I think I was in Karongi.
I think you're in Karongi, and then you came back at around maybe 2 in the afternoon, and then you attended another meeting, and then from that meeting I saw you going somewhere else. I mean, how do you manage this? Because most of the time I see you going everywhere. For me, I always do a track on you, and I see you're one of the busiest doctors I've seen, by the way. How do you manage all that? Lecturing, leadership, training, and all that.
It's planning. You just plan ahead of time, and you make it possible. My car is a moving wardrobe. I'm ready for each situation, from clothes for a formal meeting, field visit, an easy situation where we need boots and raincoats, so all of the things that I move with when I'm in the car. So that day, actually, I was in Karongi. There was a meeting that I could not miss, and it was starting at around 8. So I had to plan ahead that to make it to Karongi, you need to wake up at 3 a.m. And yes.
3 a.m.
3 a.m. And
I drive to Karongi.
Then I asked, the driving part, I'm not a very good expert to do these early or uneasy weather situations. I had to find someone also that I usually
used to drive you.
Yes. Then I asked him, what do you think is going to be the weather like? Can you see the road? One day I was driving, I think in Musanze, you cannot see the road because of the fogginess. It's very foggy. Yeah. So we just walked through, and you tell me and he would ask me, actually, Eric would ask me, what time is the meeting? The meeting is it was at 8. What time is the other meeting at Serena? I think Serena, we are supposed to be there by 1:32. Then we just calculate, however much the meeting might delay or other situation that might be, make sure that you have said bye-bye by 10, seated, and starting off from Karongi to be in Kigali at what time?
At 1.
Change in the vehicle, and you arrive at Serena. And
you attend the meeting. Wow. You really, it's really not easy. I know, how difficult is it to you? I mean, frankly speaking, how is it difficult to you? Do you think it's easy for you?
It's hard. It's hard. Actually, for that particular meeting, I wished it was going to be postponed, but it was not possible because we had postponed it at once. This is again the planning. You always have things that are going on, and you have to prioritize. You have to reschedule. So it was unmovable, and I had to do it. And you just adapt.
Sure.
You just adapt to it. But if you get too many of those situations, then you break. So it should be maybe once every 2 weeks or once a month, not a very recurrent event. Otherwise, you get too sick from it.
So, Doctor, as a clinical lecturer, you're also shaping the next generation of healthcare professionals. How do you integrate your real-world experience into your teaching to inspire future doctors? The reason as to why I came up with this question is that, to be sincere, you know yourself. You know the kind of work you do, and you know how it is intense on you. You do a lot of work. Do you think this is something you're planting into the young people you're training? Because we need a lot of people who are like you. I mean, we need people who can work multiple tasks like you do, who don't look at the pay. Because if we are to talk about the pay, I mean, no one would work. The health department, the health sector is a highly demanding sector, and if you think about the pay, then I'm sure you wouldn't be doing what you're doing. So this is the passion, hardworking, loving the country, and doing your best to do your work. So how are you branding this into the young people you're training? How do you do it? Because I strongly believe there's a way you do it. I have that feeling. Just tell me.
Simply because it's possible. It's possible, and it's doable. It's something that can be transmitted as well. We also get lessons from our parents, family circumstances that we've lived in, and maybe just to go back a bit. When I was young, I used to hang out with my mother all the time. So I was very close to my mother than anyone else. Probably, I did not even see her as my mother. She was just a friend. Then there was something that I did not like about her. It's whenever she would tell you, you are learning too slow, as if I would be here all the time. So now you pace up. You started to
Sure.
to be awake, and when I started to work also, I see myself more of someone who will not be here all the time. And you always wish what I'm doing today, if someone had to do it tomorrow, how best do you want to do it? Even better than you. So you always wish to find someone you can have doing things beyond self and better than you. Even you accept that someone can be better than you, this is another thing. Because again, time is not always on our side. So that's why I want to reflect that it's possible. It's possible to do things. It's possible to take more tasks. It's possible to do. It's because you hope for the best. What we were yesterday, we can be better tomorrow. I have seen when I was around age 9, 10, 12, there were already problems. But I very much like the fact that I was already kind of considered as someone who can contribute to solve a thing or two. They ask you to do things and you feel proud about it. There were little things, of course, consider the age that we had, but you feel like I can do something that is valuable to someone. Then with time, then becomes more shaped. You take responsibilities, and you hope they will continue also after you.
This, I think you saw me laughing. I was still laughing at what you said, that your mom always used to tell you that you're learning too slow. You're learning very slow, so it's as if she's going to stay there teaching you. How often do we have this mentality, what we're impacting, to tell these people that, you know what you saw? I was saying that I was laughing at that, where your mom was telling you that, you know what, you need to learn fast. It's as if it's someone waiting for a train or something, that if you don't do what you're doing fast, the train is going to go and you will miss it. I mean, this is really very, very genius of her. I mean, so she always told you need to learn fast, because anything can take me before I teach you what I have to teach you. Is it that?
Yeah, it was in that context. And as a child, I did not like it. I did not like it because, it just did not resonate well. Because as a child, I just want to have everything. Then she repeated it again and again and again, and then I started to take on responsibility. Very little things like, can you hold this for me for 1 hour? And you do that, and you feel so proud, like you have done something that people are validating as useful.
Okay,
Can you hold this money? Can you read me through the list of the items we need to buy? You feel like you have participated
sure.
to something valuable, and you get to go.
So do you think this is something you are giving out to the young people you're training? Are you impacting it? I mean, are you giving it out?
Yeah, some of them actually, sometimes they remind me things when we meet on the job market, or they present me in a way or another, which makes me feel a bit uncomfortable. But I like to tell people what was yesterday and what you have today, and how much true it is that we don't have everything that you want to have today, but it's the responsibility to create it for tomorrow, as the previous people did for us. It's work in continuation. So I make sure that they are not disconnected from both. And I don't also wish for them to hold on the past too much. They should innovate, and today doctors come to you with ideas that I would not have thought about when I was the same age, and you see they are going into the right direction with both passion and also trust and confidence that they can make it. Yeah.
So, Doctor, we've actually we are considered one of the few countries, if not globally, in Africa that really managed to handle COVID-19 very well. And we were appreciated by the World Health Organizations and these other organizations, health organizations. I mean, you faced a lot of challenges doing this kind of work during this period. You faced challenges then, you faced challenges during MAPAC, and who knows, we anticipate more pandemics to come. How has COVID-19 challenges that you faced, if they're there on your front line as a frontline doctor, how has COVID-19 itself influenced the current policies that we see in the country? To you, do you think COVID-19 played a big role in the changes that we see in our health sector?
Yes, it was an eye opener, if I might say so, because when you spoke about outbreak in the previous years, we had been seeing that a disease affecting Congo, Ebola, it has gone where, and you always constantly feel like we might be the next because we are just in the same neighborhood. There are different levels getting ready for something that can get to you. There's physical readiness, have the doctors buy items that you use, have paperwork on how you coordinate such an event. We had a very strong leadership support. But at the operational level, there is also moral preparation. I was working mainly with the clinical team, the treatment to the affected people, whom also are vulnerable to the virus. So one of the challenges was you rely on someone who will be with you, but the fear maybe gets ahead of them and they don't show up where you are supposed to be meeting to provide this treatment. So that's something that is yet to be solved, but at least
you mean the fear to contain the virus?
They fear to get the virus when they go.
Fear to contract the
virus when you go on the front line.
When you go on the front.
And you're supposed to be 10, and now you find only 2-3 of you.
That happened.
It happened.
So you were like in the case where, let's say maybe you've traced 10 cases in Musanze, and in that area where you've traced 10 cases, you need 10 doctors or let's say nurses or let's say practitioners to be there so that you can trace other cases, but you find that you get only 2. Who comes up? Is that what you're saying?
To trace, yes, because fear it's just in our nature. People.
How did you handle that?
Well, then if you
as a leader,
if you find yourself you are outnumbered, you are fewer than what you expected, it doesn't mean that you will go back and find the missing people. Then you organize yourselves like among us. Then let's divide the roles. And again, as I said before, just do your best. Do your best and report back. And we had leadership around us, this command post, of course, they'll be aware of the situation, and it's going to be, as you're busy treating, it's in their role now to find other forms of support that they can provide to you. It does not end there, because you also need that confidence that what you are doing, what challenge that you have, they are properly documented, and someone else is acting on it. It's not your responsibility, like you are part of a team, that larger team that each and everyone is complementing everyone's efforts. So it's not the end of the world, but for weak hearts, you could run away too, but you have to make sure that you don't.
Doctor,
Yes.
are there some policies that we have today that we've adopted maybe since the end of COVID-19? I think that's 2022 to date. Are there some new policies that you can highlight that have been put in place and indirectly influenced by the existence of COVID-19 by then? Are there?
I would just say that the guiding document that we have that tells what to do in times of such situation is improved, because it is incorporating a true experience from the front line. Before COVID, we had documents, of course, but we had not experienced those situations. So we constructed the document based on information from neighboring country, Congo, and other partners. But with COVID, we did make it more fine-tuned to reflect what can exactly happen in such situation. And within COVID also, we see that the total years of COVID, we are not of the same severity. We all remember the Delta variant situation. That was probably the most dangerous part of it, which also boosted our understanding and knowledge what to do when you face a virus that was 1,000 times more infectious than the previous version, and very little. Remember, we had a lot of deaths during
that period of
the period Delta virus. So that's actually when you have now the most second thought, myself, from the health professionals. Maybe the Omicron was fine, but the Delta variant actually can expose myself even to die. Like, they start asking questions like, what happens if I get it and die? And you fine-tune your guidelines to address all those issues. So there are many, many great lessons that we have learned. Yeah.
So, if I may ask, are you proud of where we are now?
Absolutely, very proud. I think.
Do you think we are at a level where you feel like, a lot has been done and we are good to keep here? Or is there something you're looking for that you want to see happening in the health sector that would make you more proud?
I think I'm very happy for where we have what we have done up to now. But people like me, we also get, satisfied easily, because we would have seen much worse than that, and we think this is God. Look at the hospitals, are very well painted. They are healthcare providers. The numbers are there. There was a situation back then where even accessing the services was impossible. There are years where we had many people dying from their homes, unattended. There was time I would be at Seashuka and tell people that I'm very happy. But that was not enough. That's when I knew that I am not best fitted to continue, because you want someone who come and say that this is good, but not good enough. Just give another level of challenge that would boost it even further. Yeah.
I mean, when you look at the training part, you've laid out the 4x4 strategy of coming up with quite quadrupling the number of medical doctors. Is it quadrupling or
Eh.
yes, quadrupling the number of medical doctors in the country?
The number of workforce,
Number of
all
workforce.
combined.
All combined.
Mm.
So, sincerely speaking, I'm sorry to say, but I think when I look at it, as someone who has been, following up the health sector for some good years, I tend to have a feeling that are we not going to have half-baked on the side of doctors? I mean, the workforce is big, having all combined is quite big. But on the side of doctors, nurses, and practitioners, are we not going to have a bit half-baked doctors? The ones that are not really well trained. Because look, I'll give you a simple example. During COVID-19, all of us were complaining, saying, you know what, it's not possible. We cannot have this vaccine in this period of time. It's very impossible. This vaccine was there already prepared for this. That's what most people were speculating. And it was hard not to believe it. So if you tell me that we are supposed to have maybe 50 specialized doctors in 7 years, and then you tell me in 4 years we are going to have 100 of them, yet it takes 7 years usually to have that. I mean, I don't understand it. Maybe if you can really educate me on that, and people listening.
Yes. So 4x4, as I said, it is not medical doctors. Maybe that's one of the things that we have to transmit very, very clearly. It's all the health workforce. Medical doctors in different categories. Medical doctors in the categories of general practitioners. That's a training of 6 years. Medical doctors in the category of specialist doctors. That's a 4 years training.
After the 6.
Medical doctors in the category of subspecialist, the super specialized. Again, it's between 2 and 3 years. So we have a task to quadruple within each category. We need more GPs, general practitioners, we need more specialists, and we need more subspecialists, because that's how the pyramid is built. And you have the same in the category of nurses. You have nurses that train over 3 years. You have nurses that train for 4 years. You need them in each category quadrupling. And you have specialized nurses as well. A nurse specialized in cardiology, a nurse specialized in anesthesia, taking care of people with kidneys. So we also need those, because if the doctors develop, the nurses also have to follow along. If I am
we need them.
even the job, the way the layout of the units detect that we do. So if I am a doctor that opens someone's chest to operate on the heart, I want also to be working with a nurse specialized in that, so that surgery is supposed to take 4 hours, it takes 4 hours. If you work with a nurse who is specialized in something else, who have no idea what it is, the surgery may end up taking 8 or 9 hours because of inefficiency. So the language has to be the same. So the pharmacists, allied professionals, all have to be quadrupling in the same years. Of course, for general practitioners, you start today. If you start today, the implementation 4x4, at least you know that after 4 years, you have people in pipeline. They have not yet graduated, because they have to respect the amount of years required within that training category, then the amount of content that they should go through, the examination, they have to qualify for that purpose. But the start has to be as early as possible, because the journey is long, and so that's the essence of 4x4. So the half-baked, it's not true. Many people had such reservation. We are going to have the numbers and the quality.
You need to break the silence now.
Yes,
Because now you need to be
the
clear.
quality will not be compromised. And this has something to do in the past. I don't know where we got this feeling like the good doctor is the rare one, the one that you can see, the one that makes you drive 10 hours, the one that makes you wait for 6 hours. That must be someone good. That has to be someone very special. So you have to break this philosophy. A good doctor should be the one that is available for the right purpose and the right skills. So if I give you 2 appointments, for example, there's Dr. A is available in 1 week, and there's Dr. B is available in 5 minutes. Someone might feel like, I prefer to wait for the one who is not easily available, must be the good one. No, actually, it is completely wrong. A good doctor should be available for the right time, right purpose, and with the right skills. So this is possible in 4x4, and we are already seeing significant results, positive signal that actually we should have started long ago.
I mean, that was my question. So that was what I wanted to ask. What had delayed it?
Well, if you look at the health sector journey of this country, the first 10 years it was crisis. Right after the genocide against the Tutsi, there are many problems and a lot of organization to do. I think the doctors by then, like around 30, only 30. Now they are almost, all of them, they are retired. Professor Roma Sirabo and all of those. Those are the people who restarted the system. There are very few with different mandate. Yes, he's retired now. Different mandate, manage the crisis, put things in order. Let's just reboot. Let's just restart the system. Then the following 10 years, it's some level of organizations, programs, TB, malaria, community health workers, community health. Your hospital should be like this, even if it's empty, but you have to bring it up. And then the 10 years that follow is more of fine-tuning of, strengthening, of course, of what you had yesterday, the primary health care and other development. But now, how do you fast pace to catch up with what you have missed? Because a lot have been missed. To catch up on time, to respond to the needs. The needs don't stop. The disease ecology changes. Today we talk about cancers, we talk about NCDs. Like, what are you going to do to be at the same pace? The population grows. Yesterday you were 9-10 million. In the next 20, 30 years, you'll be 50 million. Are you able to respond to needs at that time and today? So that's the philosophy behind 4x4. It's not limited in time. We say quadrupling in the next 4 years, but it's something there to continue in the same framework, in the same philosophy of being able to be resilient and sustain yourself. Because when the population is healthy, then you can talk about the economic development.
Sure.
Yeah.
So the other question is, when you assumed that position at the Ministry of Health, I assume you had a docket, you had things on list that you had to do. What have you so far accomplished?
I wouldn't say accomplished me as a person, accomplished as a team. I think me joining the ministry from the hospital, I think I was a positive addition to the great team that was already there, because I was able to connect my intervention with what I have just experienced, what is on the ground, what happens in the emergency department in 24 hours, what happens to the providers in different categories. So we bring that eye as well. You bring that component into the planning so that it gets computed in the implementation. You probably have heard me saying again and again, we are quadrupling the health workforce so that we can be at the minimum required density of health workforce for any country. Already we are understaffed, we are short of workforce by 4 times less. So which means every doctor, every nurse, every pharmacist, every porter, every driver, every lab scientist that you have seen in any health facility, they are doing a job that was supposed to. Yes. 4.
They're doing a job of 4 other people.
Yes, themselves included. So they are 4 in 1.
They're 4 in 1.
Yes. So how does 4 in 1 feel?
It's 1 in 4 actually.
Yeah, it's 1 in 4.
Yeah.
So how does it felt for someone who's looking for the services, delay, superficial interactions, errors that might be introduced, appointment that you cannot schedule? So it has to be translated to the other side so that actually people get on the same page and they understand each other and support each other. Yeah.
So I have some side questions that I wanted to ask you. So this one, in the midst of rapid development, what are the most significant resources or funding gaps you see in our health system today, and how policymakers and stakeholders work together to ensure that quality care is accessible to all? I mean, what are some of the gaps that you see that needs to be filled?
Yes, from the training component, maybe we just remain within the training component because that's the area where is my most of expertise, not the finance part of it. Within already the 4x4 as it sounds, when you say 4x4, it means facilitating someone who's going to access that higher education scholarship. We have great people out there who did not have the required financial resources themselves to access education. And money is something that we can all contribute to, like scholarship gaps, supporting a young, smart trainee to undergo 4 years training to improve nursing services at your local hospital, midwifery services, surgical services where you are. So we do map the training slots that we have nationally, and people sign up for these slots. Some are sponsored, some are self-sponsored. But in the 4x4, ensure that we occupy those training slots to the maximum. If there is a trainee who's left behind and they don't have the means to pay, roughly it takes, for example, 7,000 USD to train a nurse. You just mobilize for it and support that training. So scholarship gaps, these are the things that we map every year when the schools are open for enrollment. Equipment.
So before you go there, I mean, since you joined, just help me understand. Are there some numbers that you remember that have come in, have been trained because of your rapid support and mobilizing and telling your heads that we need to bring these people in. We can't leave them behind because we need these numbers. Are there some cases where it has happened?
Oh yes, absolutely. Absolutely. We did it at Ruri Higher Institute for Midwifery Programs at Ruri. That's where we started. We did that at East Africa Christian College. We did it at Kibogora. We did it at Kabgayi Institut Catholique. We did provide scholarship support to people who are eligible for this program to start their education.
These are people who didn't have the capacity to pay for themselves.
And that's where come what we reported back, I think by December 2024, that we managed to increase our enrollment rate by 3.7 times to what it was at baseline, so by active provision of scholarship support.
The enrollment rate was?
We are around, historically, we are enrolling as a country 1,600 trainees.
In the medical sector?
In the health-related program in year one, like in 1 year. But by December 2024, we managed to enroll close to 6,000 by providing extra scholarship to people who meet the entry criteria to undertake these programs and who had expressed the need to be supported, and we had the support that they needed.
So before there were those who made the criteria, but because the slots were not there, they could miss out.
They could miss out. For example,
yet they were meeting the criteria to enter the program, but because the budget was kind of low, they would not be admitted. Was that before?
Yes, the budget will not be a lot. The budget is standard. The school fees, the tuitions are standard, but that's the money that they did not have that we could mobilize for. For example, if you look at the training slot that you have for midwifery program, they are being occupied only at 20%. they are available, infrastructure, curriculum, lecturers, but the students don't have that money out of the pocket to pay for their tuitions and sustain themselves at school. So these are the things that we've been doing and we continue to do together with the team at the Ministry of Health.
So, why do our country, I'm one of those people who tell many people out there that however much we judge our health sector or talk about it or something, we have a very strong health system. I always tell people that I've had a chance to move around East Africa. I've seen how they operate. I always tell people that, you know what, in the 5 years period, Rwanda in the health sector has done things that maybe they would have done, they would do in 20. That's what I strongly believe, because I've seen it happening. I've seen ILCAD Africa coming up. I've seen the BioNTech. I've seen there's so many institutions out here that are dealing in the health sector that have come up within just after COVID. So that for me gives me hope that we are headed somewhere nice. But as someone who works who is always there, what are some of these strong big challenges that you think that are down there that are affecting these local people to access good health, that can easily be resolved on the health, just on the local level? What are some of the things that you think we need to understand, and people are not taking serious, that are hindering our good rating in what you're doing in the health sector? Because you're doing a lot, but do you think it's giving impact down on ground? Are there not things that you think need to be maybe mindset, maybe changing the way we see things? What are some of the things that you think are still hindering our progress in the health sector?
They might be misclassified at mindset problems and everything, but I prefer to always say communication. Communication has to go both ways. You tell me what you need, I tell you what I'm doing about it, and we just meet somewhere halfway. And communication with the ground level also can be changed or altered if you use foreign language to communicate. I think we have to find a way to put it in the simplest way what we do and report back to the population who needs to hear it in the language that they understand best, so that when they ask the question or follow-up questions, it's something else. I've seen people that I did not receive good treatment from hospital A. It is true, but we want them to own the entire picture. Like, don't say I waited for 5 years for a dental clinic at this hospital A in my community, but also check other things that are there for you to know because of A, B, C, D, because you play a big role in ensuring that it is corrected, it is addressed in a timely manner. Who goes to medical school or dental schools? They're the children from the community. So.
Sure.
It's something that we have to improve on, like back and forth exchange, back and forth communication for a question openly, and being also willing to take feedback, be it good, be it bad. It's there for a purpose. It's there to attempt to modify the course and make things happen much faster, especially that we are not going to be here always. Everyone has a time in which they have to contribute the maximum, then someone else come in. So we want to leave the room in a shape that is decent.
So, Doctor, I want us to talk about with the increasing push that we talked about, I want us to talk about the technology. Why are we not, we've not yet brought up the strategies that deals with allowing people to do telemedicine. I see people doing it. I see some small websites, people are doing it here in the country. I don't know how they operate, but I see some are selling, drugs on those websites. Some are selling, some are telling you that they can give you consultations, but I don't know how it operates. Do we have already the guidelines on how to do that? I mean, why has it delayed? Because some countries, even the neighboring countries, are really doing it.
Yeah, it's a strategic direction for us. We all want this to happen at some point, but it can be also sensitive in a way that we are talking about conversation between two people, health information that is being collected throughout the telemedicine consultation that require a very high level protection for XY years. So those are the ABCDs that are being ticked to ensure that it's kickstart with the strength that is required. You don't want to start it today and you stop it tomorrow because of this and that issue. It also has layers of preparing actually the population we serve, that telemedicine is here, it's for this purpose, this is how I'm going to protect your information, this is how I'm going to link you to the insurance, this is how I'm going to reimburse you if you incur any cost that require me to reimburse you. So all these details are required to engage the RISA, for example. When you talk about information security, which platform do you want to use? How sure that you are protected, you cannot be hacked? Where are you going to store all these medical records? How are you going to be retrieving them? How are you going to ensure that they are not lost over time? Because if I have a medical file at Chuk or King Faisal Hospital, it's for life. They should have it at least accessible every time I go to them. So when you move online and you can't retrieve it, what do you do? So all of these details are being checked. Which devices to use so that you can see clearly the person that you are giving advice to. You can see clearly the rash. So all these details are very... But that's the strategic direction for the country, and we are all involved.
My last question is everyday safety practices. As an emergency and accident expert, I don't know if I'm bringing it correctly. From your experience, what are the most common causes of accidents in Rwanda, and what practical safety measures can individuals adopt in their daily lives to reduce their risks?
Well, in my time at the emergency department, we did have actually more than roughly around 50% are trauma-related emergencies, road traffic accidents, and these are bus rollover, motor-to-motor collisions, and it has to do with many things like drunk driving, the drivers that are actually able to maneuver in these hilly sides of the country. All of these technicalities do play a role to have a bus rolling over speeding, the attitude of the person who's driving, the training that they would have received. So this will lead to these motor vehicle related accidents. There are also things that I could flag related to bicycles. I think countryside people commonly use cycles, and the bicycle lanes that are yet to be very well demarcated and developed so that bicycle can pass, but if you can pass without one or that colliding with each other. Then there are the man-made trauma-related assault and physical trauma related to people fighting and stuff like that. So those are the traumas that we are managing. So you have to go down to that level of detail and just tick corrected each one of those details. There's no like one fit all solution for it. It's not a unique challenge for us. I think trauma everywhere is there as you urbanize, and the density of people living in certain areas. As it gets busy, you expect more of this that you can contain.
Sure. So the first aid, I mean, let's say most of us, we see a bus rolling over and we don't know what to do. Some people run away.
Because of fear.
I mean,
fear of blood.
Fear of blood. Those with we call them with hard heart. might go and serve people, but what is it that really, for those who can really even go and thinking they go to serve people should do before the ambulance comes in, before the rescue comes in? What is it that we should all learn to do away as we go on the roads, because it can happen anytime on you and someone, your friend, or
Yeah, actually, basic life support should be. It's not something for the health professionals. It should be for everyone. In countries actually that face these problems more than others, this is done by anyone, as any bystander can do that. You put the skills that you place in students, motorbikes, riders, everyone who is likely to get there before everyone else. And people also contribute in different situations. I might be not comfortable as a lay person to provide basic life support, maneuver, positioning, arresting the hemorrhage, but I'm maybe good at least calling 912. That also contributing to the response when such emergencies happen. I remember the SAMU did have sessions with motor riders, for example, because they are very mobile. They are easily maneuvering to the side. They can get there. So they were given a basic life support, and the future development, we see more. We are seeing more ambulances actually today. I think close to probably 500 or 600 ambulances staffed that can the system of monitoring or communicating from the crash site to the 912 is more and more improved, digitalized. You can geolocate a call, an incoming call, so that you don't waste time asking them, is it around the corner? Where is the color of the building nearby? You can already see this in the screen. So it's getting easier, and you will see more and more people invited into the response for different roles, starting from the lay people, or the bystanders.
So, Doctor, thank you so much. But if you have something that you really feel like I've left behind that you came expecting to speak about, please, before you can talk about it and you can tell us that thing that is really deep down in your heart that you wanted to share.
To thank you, just to thank you. Actually, you did. It was very comprehensive. It's not the first. It's not going to be the last. It's the first, but it's not going to be the last. We can always engage. Thank you for the invitation, and looking forward to meeting in normal life or similar sessions in the future.
Sure. So thank you so much, everyone, for tuning in at Rwanda Health Magazine Podcast. My name is Arafat, and we were discussing with Dr. Menelas Nkeshimana. He has shared a lot, and please take your time and listen to this and watch the video, and please, we beg you to subscribe to our YouTube channel and follow our conversations. We do everything related with health. We bring you qualified and compassionate doctors to discuss with you about health, about diseases, and the treatment procedures that are new and the ones that they use to treat you. See you next time.